Alors, bonjour de Montréal. C'est un grand plaisir d'être avec vous aujourd'hui. Mon nom est David Heurtel et j'ai l'honneur d'être coprésident Canada de ce forum virtuel organisé par Metropolis, Amérique du Nord. Welcome to this two-day virtual forum organized by Metropolis North America to showcase the research on the Canadian Institutes of Health Research, CIHR, funded project on differential impacts of COVID-19 on immigrants, Indigenous peoples, and vulnerable communities in Canada, the USA, and Mexico, as well as to address the issue of cross-border movement between the three countries during the pandemic, which will be addressed on the second day of the forum. The annual Metropolis North America Migration Policy Forum has become an important three-country platform for exchanging evidence-based ideas and practices on migration and identities. The forum enables participants to share knowledge and key lessons on policy issues in the United States, Mexico, and Canada. As you have all seen, the program has brought together a number of leading researchers and practitioners from Canada, the US, and Mexico to share with you the latest research regarding how the pandemic has affected migration, Indigenous peoples, and vulnerable communities, as well as a number of wider economic, social, and health issues brought about by the pandemic. I am the Canadian co-chair. My name again is David Heurtel of this event. And we also have as co-chairs Gustavo Mojar from Mexico and Ann Richards from the United States, who are co-chairs that will be addressing you tomorrow. Note that we have AI text translation into French and Spanish for this session. I will now ask Professor Laurie Wilkinson to take over. Laurie is one of the leads of the CIHR research project and is very much involved in the Metropolis and other research projects in the field of migration. She will introduce our keynote speaker, who has a fascinating presentation to you all. Dr. Wilkinson.
Thank you, David. I join you today from Treaty 1 territory, where the University of Manitoba sits on the lands of many different nations, including the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and we are also at the homeland of the Métis Nation. At this time, a recitation of this treaty acknowledgement feels fundamentally shallow, but it is important for us to acknowledge the immeasurable losses that have come to light in recent days. Together, we recognize and share our deepest sorrows and condolences with our Indigenous friends and relatives upon the rediscovery of bodies of 215 Indigenous children at the Kamloops Residential School in British Columbia, followed by the discovery of the 751 unmarked graves at Cowessess First Nation, which actually happens to be very close to my hometown in Saskatchewan. We know these children lived, were loved, and are deeply missed and mourned by their families and friends. We recognize the voices of their families who begged to learn what happened to their children and were ignored and silenced. We acknowledge the atrocities that were inflicted upon our Indigenous friends and families, and as human rights scholars, we must strive to dedicate our service to accounting for our genocidal past and to create conditions of true reconciliation and collaboration. One reason that these acts of genocide remain hidden and denied is because we have allowed our government and various religious institutions to deny most of what happened in residential schools in Canada. This cloak of silence and unquestioning of religious and government authority has made the suffering of our Indigenous family and friends prolonged, more painful, and prevents true reconciliation. So I'd like us to keep this in mind as we start this conference today. But it is my great pleasure to do a lovely task of introducing my colleague and friend, Dr. Julian Arino. He is a professor in the Department of Mathematics at the University of Manitoba, and he is joining us from the south of France, where he's continuing to conduct his very important research on tracking the spread of coronavirus. Dr. Arino's research primarily deals with the mathematical population dynamics in epidemiology and ecology, with a focus on modeling population movement. Dr. Arino specializes in spatio-temporal spread of infectious diseases, with a focus on the relationship between modern commercial aviation and the fast global spread of infectious pathogens. Dr. Arino uses modeling and graph analysis to consider the risk of importation of disease to various public entities. Other areas of interest include the stress imposed on public health systems by public health practices around the world. For example, the treatment of infections or vaccination schedules and other problems concerning population dynamics and biology. He is part of the National COVID-19 Mathematical Modeling Rapid Response Task Force. And by my estimate, he's raked in probably $20 million of research within the last couple of years to look at modeling in various forms. Most recently, a $10 million investment he received in the Emerging Infectious Diseases Modeling, this is a fund established by the Natural Sciences and Engineering Research Council and the Public Health Agency of Canada. Thank you, Dr. Arino, for joining us today from France and for sharing with us your really important research. So I will give the floor to you.
Thank you, Laurie. Can you see my screen?
Yes.
Yep. Okay. You're a bit over the counter. I would love to have raked in 20 million, but it's less than that. But still, I think there was quite an investment in this problem, which is good. Okay, so what I want to talk to you about today is problems related to mobility, what I'll call case importations, which is when diseases cross boundaries of any type, and the spatial temporal spread of infections. And of course, I'll talk about this in the context of COVID-19, but I'll try to also give you historical perspectives about these aspects. Actually, Laurie, I'm still one day in Paris. So currently I'm still in Paris. I will be in the south of France soon. But for now, I'm visiting Sorbonne University, which is here in Paris. Okay, so first of all, I'll start with the end this way. If I need to stop early, I'm good. So I'll thank you for receiving me wherever you are, your homes, offices, and so on. And I also want to thank my collaborators, which have included a lot of people over the years. But in particular, the work I'm talking about is with my host here in Paris, a colleague in the US, and a colleague at the U of M. And I'll mention that another group in which I interact about COVID is led by the Public Health Agency of Canada. And it's a group that has met weekly since the beginning of the COVID crisis. And a lot of the ideas that you'll hear here are mine, but they come through discussions with some of these people that are in this group. And as Laurie pointed out, there's been plenty of funding coming our way. It's mostly NSERC and CIHR, but also the Public Health Agency of Canada that's provided also logistical support that has been very important. I mean, they've helped with data gathering and that type of endeavors. So I always like to start very, very early by pointing out that none of which what I'm doing is new. This is a quotation from Thucydides about the plague of Athens that happened in 430 BC. And you can see in this description of the arrival of a plague, we're not entirely sure it was plague, it might have been typhus, but it was considered a plague. And you can see a spatial temporal description of spread, okay? So it started in Ethiopia, and then it went into Egypt, Libya, Persia, and then it arrived in Athens, Piraeus being the port of Athens, and then went into the upper city, and there the deaths became more frequent. So that's almost 2,500 years ago. It's probably one of the first descriptions of a plague, but you can see that this feels very modern, and I'll come back to see this at the end of my talk, just for an additional remark. So the first thing I want to do is go back a little bit in history. Well, go forward from 2 CD this, but go back a little bit from the current history to talk about the role of movement in the way a disease becomes spatial. And by spatialization, I mean the fact that the disease starts to move about in space. Now, the first thing that I'll mention is that if you think about them, epidemics, they're spatial creatures. They're bound to move, essentially. But one of the aspects that's often neglected is that many pathogens involve several different species. So you can have, and that might have been the case with COVID-19, for instance, you can have diseases that are endemic in some species, and then there's a spillover event and they cross into another species, and in that species they have different characteristics in terms of infectivity and so on, and so they start spreading in that new species. But that means that oftentimes when you're thinking about controlling a disease, you can control one species, humans for instance, but if you cannot control everything, it doesn't help that much, okay? And the other sort of recurring theme in my discussion today will be that pathogens, they don't really care about borders. So I'll talk about this in terms of how this sort of combines with COVID and so on, but that's one of the main sort of key messages here. So I said I would start with a bit of history. This is a major traumatic event. This is the Black Death in 1347 to 1351. This is a French map. I'm sorry, it's written in French, but I think the intent is visible. And so what you can see here is the arrival of Black Death in 1347. It actually made it in 1346 here, but the main point of arrival in Europe was through Sardinia and Corsica, and essentially the southeast of what is now the southeast of France and the southwest, the west of Italy. And then what I find interesting in this map is that you see what we call a nicely organized traveling wave of the disease. So the disease made its way into, made landfall essentially in 1347. And then these waves show you how the disease propagated through Europe through the years. Okay, and it took 5 years essentially to get the furthest it went. So this is things we still observe, for instance, with rabies or other animal diseases. But for diseases of humans, this is not something we see very much anymore, and I'll come back to that. So you can see this slow progress, and I'll point out that this was a major traumatic event. I mean, estimates vary quite a lot, but essentially people think between 25 and 50% of the European population at the time was decimated. So it is a very important event in the history of spread of diseases. And what's characteristic with that previous map is that you can correlate it very much with trade routes. And that is a constant in the way diseases spread, is that, the diseases of humans, is that they follow human trade routes. So that's about 100 years earlier, that were the trade routes that were prevalent at the time. And you can see this arrival that follows exactly the same pattern as we saw for the plague itself, okay? Now, things have changed, and this is one of the main sort of evolutions that we see, and I'll sort of document the change. So where I will be soon, as Laurie pointed out, I will be in the southwest of France. I will be in that city here. And that city has a particularity of being the birthplace of one of France's kings in the 1500s. And I point that out because his mother, this woman here on the picture, she was living close to Paris, and then she, when she was about to give birth, she was essentially not quite the Queen of France, but she had very, very high status. When she was about to give birth, so that her son would be born in the natural seat of power of kingdom he would start governing, which is in the south. She traveled from Paris to this town called Pau. And the important thing is that even someone of high status as she was, she took 19 days to do this 800-kilometer trip, which is something that I do on a train now in 4.5 hours. I am not King of France by any means. So you can see how things have evolved. And that's quite an acceleration from what we saw before. That was already much faster than 200 years later. This is something I found on the web somewhere, which is actually quite topical with respect to what Laurie was pointing out, if you look at what's written up in the bottom there, but I want to focus here on the travel. So this advertisement says it's only 15 days to go from Liverpool to Winnipeg. So the same amount of time that that person 300 years before, or 300 and something years before, took to travel from Paris to the south of France, 300 and something years later, it takes you from Liverpool all the way to Winnipeg. So there's an acceleration of traffic. Okay, and now fast forward to nowadays. This is the global air transportation network, very sort of idealized. What I'm showing you there are all the airports in the world, and the dots indicate the degree of an airport. So the highest degree, the degree in terms of a transport network is the number of locations you're connected to. And so this shows you that Heathrow is typically the largest degree, but there's places in North America, places in Europe that have high connectivity and places with lower connectivity. But the important thing is that this has shrunk the world in terms of the availability, well, the way people move around. And this is something we had looked at, for instance, this was prior to the Olympic Games in London. And I want you to focus on the bottom of this map, not on the pointy things, but this is showing the average minimal travel time to London from all over the world. And what you can see is that there's very few places where travel will take more than 24 hours on average. So in terms of moving diseases about, this indeed changes things, because if you go back to plague, we have this 5 years of spread of the disease over the European continent, whereas here you can see it takes an hour to a day to go from anywhere in the world essentially to London. And the number of people that are using this means of transportation is also increased dramatically. So this is the total number of passengers transported per year by the air transportation network. And what you can see is a massive increase actually already since the 2000s. We've more than multiplied by 2 the number of passengers transported in 20 years. I'll point out that the last year there that you see in the data is 2019. 2020 would see a massive drop in transport, but the data weren't available publicly when I made that graph. So, and here, let me show you. So that's the consequence. Remember this nice traveling wave that we were seeing before, nice, I shouldn't say nice, but okay, a very prettily organized traveling wave. And here, this is COVID in the US. I planned to do Mexico and Canada as well, but I was having trouble mapping. So what you're seeing here is the incidence, and I've limited it at 100 because I'm having issues plotting. But you can see that activity is really all over the place. So there is not that nice organized spatial pattern that we were seeing before. Now things seem to be more almost chaotic. I mean, there's some places that are active at times, other places that are not, and etc. It's much more difficult to grasp how the disease is moving about these days. And this is characteristic. If I had plotted other jurisdictions, national level jurisdictions, we would have seen the same pattern. It's really complicated. Okay. So I'll start by discussing case importation. So for the moment, I was showing you how diseases move in sort of globally. But now I want to focus on the mechanisms that lead to this global movement, and in particular, what is called case importation. And so this is very akin to things that have been done in ecology. And in ecology, we talk about introductions. And they've been studied for quite a while because introductions are one of the drivers for evolution. If you think about how species evolve, they evolve because of mutations that are within themselves, but they also evolve because of mixing with other close species. So introductions are very, very important in ecology. And they're also all the more important in recent years because, as usual, humans have messed the entire system up. And what has happened as a consequence of that is that there are introductions at a rate that is much higher than before. And that has perturbed ecosystems. And so there's a lot of studies that have gone into that. For diseases, I'll call importation, whenever you have an individual who has acquired the infection elsewhere and in given jurisdictions, I'm going to think really from the perspective of jurisdictions, okay? I have an individual who has acquired their infection in one given jurisdiction and moves to another one while still infected. Whether they are detected when they get to that new jurisdiction or whether they infect someone else is irrelevant to the importation itself. It is relevant to the success of the importation from the perspective of a disease. Okay. And what's important to see here is that geographies, they really influence the way you think about this. Because if I think at the country level, importations quickly, they don't play any role. I mean, once you've imported the disease into a country, there's a lot of internal dynamics that happens, spread of a disease within communities. Whereas if you're thinking about an isolated jurisdiction, for example, in the north of Canada, if you have 500 people and there are no cases and they import one case, then it's a major thing because maybe after some time they manage to forbid any more spread, but then an extra importation will once again be a problem. Whereas this is something we don't really see at the national level. And I'll illustrate first I wanted to show you, I mean, this is just a very brief movie that I made, which is to illustrate how you can think of importation. So here the red people are infected. And what I'm doing is I'm moving people between locations, and you'll see that at one point, the disease jumps to a new location. And that's how I think of importations, okay? So there's these internal dynamics that happen within a location, and combined to that, there are transport events when people move from one location to another, okay? And as I was saying, so at the top jurisdiction level, there's no, I mean, it's very, not simple, but it goes in a very understandable way. So this is the number of jurisdictions that country or territory level jurisdictions that imported COVID-19 as a function of the start date, which was, I think for this data, January 22nd, 2020. And you can see that, and for comparison, I've compared with SARS, the original SARS in 2003. And you can see that originally it's a bit the same, and then SARS CoV-2 really started picking up, and now there's a few more. We're at 194 jurisdictions that have reported cases, and none have ceased to report. There is no jurisdiction that has imported cases and that now says, I don't have cases anymore. If you drill down, and that was what I was saying before, if you drill down into lower level jurisdictions, you see some change. So here, for example, I'm showing Canada, Mexico, and the US, and this is the number of, so in Canada, it's health regions, of which there are 125. In Mexico, it's municipalities, and in the US, it's counties. And this is showing the percentage of these 125, 3,000 something, and 2,000 something for Mexico, that are reporting cases over a 3-week period. And you can see that by drilling down into the details, we see more variation. So whereas the countries are still reporting cases, because you're looking at a top level jurisdiction, at a lower level jurisdiction, you have this oscillatory, this changing behavior, because some jurisdictions resolve their infection, the infection has gone extinct, but then they might re-import the infection. And so the dynamics, whether you look at it at the country level or lower, changes. And so in terms of propagation, so what I was showing you earlier in terms of the spatial spread, you can think of everything in terms of being very much driven by importation. So there is transport from one place to another, and then there's an importation event. So someone comes from elsewhere and imports the disease into a new location. There might be local amplification and then potentially exportation. And it's the repetition of this process that leads to this spatial process, this spatial expansion that we saw at the beginning. So very briefly, I'm not going to show you any math, but I'll just explain how we think about this type of problem when we're modeling things. So the idea is we use what's called a compartmental epidemic model. And the idea is, and you've probably heard quite a lot about this, so I won't get into detail. We think of individuals as being in several different status. So they can start off typically as susceptible individuals. So they haven't acquired the disease, they haven't been in contact with it, and they are about to, well, they are potentially infected by it. And then there's latent individuals, these are these L compartments, who are people who have contracted the disease but are still incubating with it. And they're typically dangerous in terms of travel because they are not detectable typically. Okay, they can travel, they're incubating, and therefore they can bring the disease to a new location. And then in terms of COVID, we have two possibilities. We can be undetected, so you haven't taken a positive COVID test, or you can be detected. And this is what this model says. Okay, so I won't get into more detail. The idea, though, here is that we're considering importations. We're interested in how importations affects that problem. So these arrows that you see coming on the side here with the lambdas, they represent the importation of new cases. So these are people, we typically assume people that are detected don't travel, and the others, they follow these arrows and potentially they come into a location. And we're interested in the role of these arrows on the dynamics of the disease. And so essentially we're doing something like this. We're throwing cases. This is modeling, okay? So the idea is try to investigate the mechanisms that deal with this, that lead to importation. So we throw in cases here and we see that these cases enter the model and we try to see, so I've got this thing that's in the way of my, okay. And we try to see the response of the system to this, and we can envision 3 types of outcomes. So I can throw in a case and it doesn't lead to any any transmission locally. So that's an unsuccessful importation from the perspective of the pathogen. Or they can be a minor outbreak. There's a few cases, but it resolves very quickly. Or there's a major outbreak, which we've observed most places. And so we can look at this, because it's a model, we can play with the numbers, we can try different scenarios. And here what we did is we looked at the average time between importations. So remember these arrows that come in through the side. And so we look at how much time it takes on average between moments when cases come in, and also how good a job the local public health authority where the disease is being imported is doing at keeping control. And what you can see is that if cases don't come very often, this is the probability. Essentially, it's 40% chance. If cases don't come very often, which would be this corner here, and you're doing a good job controlling, then you don't import cases. Whereas if cases come quickly, or you're not doing a very good job controlling, you have a much higher probability of importing. Okay, and also let me point out, but at the same time, so this is what we call the attack rate. That's what percentage of the population in the locality of interest ends up having the disease, acquiring the disease over the course of, in that case, it's 3 months. And you can see, and this is the dots here, you can see that even if you're likely to import, if you're doing a good job controlling locally, then the attack rate remains low. So you have quite a few chances that you'll have a few cases locally, but if you're doing a good job controlling, these cases are not very dangerous, so to speak. Okay, and so then we started, so this was work that we did some time ago, but now the big problem that started arriving on our tables were the role of variants. So let me explain the typical ideas that we're having here. So suppose we have a variant and it's the resident one. So essentially, for example, the wild type, the original one, or now that B117, the so-called UK strain, is propagating predominantly, that could be that one that we're looking at. And to that, we add a novel variant, something like the Delta, for instance, which is more transmissible than the original variant. And the questions then become, well, first of all, how long does it take until the novel variant replaces the old variant in terms of propagation? And the answer to this is quite simple. I mean, it depends on a lot of parameters, but essentially quite quickly, a novel variant that is more transmissible than a resident variant will take over in terms of propagation. The other questions that we started to think about in this context were related to importations, and also trying to figure out the role of importations in this process. Okay, the idea was because remember when I had arrived in France when the B117 variant started taking over, and in France they decided to interrupt travel from the UK, and implicitly, I mean, for me it seemed a little probably pointless, but I wanted, okay, this is just an opinion, and I wanted to see if modeling could help us sort of untangle this question. So again, no math, I'll just explain what's happening here. So what we did is we took the model that I was showing you before and we multiplied it. So we're essentially looking at the same thing as before, but what we've done is the two central models that you see there, there's one for the resident variant, so the one that's already here, and there's one for a novel variant, okay, which is this new thing, but we're assuming that except for different characteristics in terms of transmissibility, the two things proceed the same way. And on top of that, we've added, because we were really interested in figuring out what's the contribution of importation to the dynamics, the local dynamics. And therefore we added these two things, which we called importation layers. So what happens is if you're coming from another jurisdiction and you come into our model, then you come into this importation layer. You have interactions with the rest of the community. And if you're infected with the virus, you might infect people. But because you're kept aside in our modeling, we're able to see what's the contribution of these importation layers compared to propagation that's happening within the community. And what we see is that, okay, first of all, importations, yes, they definitely play a role. So this graph here, you see that this is the dashed curve is what would happen if there was no importation. Okay, I'll throw in a few variants, wait some time and see what happens. This is the epidemic curve that I get. But then I start putting variants in regularly. And the more frequently this rate here, this lambda is the rate at which I put in importations, the more regularly I put importation, the earlier my epidemic peaks. This is just the novel variants, okay? So this is how many cases of a novel variant you see every day, essentially. And so the earlier the faster I import, then the bigger the peak, and also the earlier the peak. So importation plays a big role. What can I do to stop it? And there's two mechanisms that are sort of time proved and so on. The first one is quarantine, quarantaine, which is easier to understand if you're French because it just means 40 something. So quarantine is not isolation. There's a lot of misunderstanding of this. Quarantine is you take everybody that comes in and you put them through a system where you try to reduce the contacts they have with people within the population. So this is if you traveled to Venice in the 1400s, this is what you would meet. Your boat would go there and you would be put in this lazzaretto. That's the old one, and they then built a new one because they had a lot of trade. And when there were periods of plagues, any incoming boat had to quarantine there for 40 days, hence the name. So how we model that? Well, it's very simple. We take this model that we had before and we simply say, well, quarantine works if you're coming in and I can't say if you're sick or not, and I leave you in quarantine, if at the end of this period of quarantine, you're still infected, so you're still in one of those compartments here that correspond to people that are not detectable by the system. So if you arrive in one of those compartments and after however long the quarantine is, you're still in one of those compartments, quarantine has failed because you're joining the regular population and you're potentially infecting them. Whereas if you're in any of the other compartments, then you're done, it's good. And this is what we see. So we see that depending on the length of quarantine, this is just an example. So the blue lines show the people that have remained in the same compartment. And you can see that, well, the longer the quarantine, the higher the probability that they will not be in the same compartments and they will be detected. Quarantine reduces the importation rates, which means in the graph I was showing you before, that pushes you towards the right. And now the other way is, so quarantine is one way to lower importations. The other one is travel interruptions, which we saw a lot of. And that also is a time-tried method. I'm not going to say time-proved. So this is a plague wall in the southeast of France, which was built when there was a plague outbreak in Marseille in 1720. And just to show you how efficacious it is, here where my mouse is, this is that plague wall. And you can see that plague arrived in Marseille in June 1720. It made its way across a first containment measure, which didn't work much. And it also made its way across the, so in September, it jumped over the wall, which is completely expected. I mean, these things don't really work. And in our model, we see the same thing. Here, what we've done is we've taken the same model, but what we've said is we'll interrupt travel into importation completely. So that lambda, these arrows that come in the side of the model, I shut them off after 10 days, 20 days, 30 days, etc. And what you can see, this light blue curve here is what happens if I shut travel off within 10 days of the start of the propagation of a novel variant. And all the others is if I wait more than 10 days. And so what you can see is that there is essentially very little effect of travel interruptions, except if I do them very, very early. But typically, I don't know at that time, 10 days into the spread of a novel variant, I have no clue that a novel variant is spreading. So all those travel interruptions serve very little purpose because the variant is already implanted and it's the local, population, community propagation. So within the population, as compared to from the importations, that is taking place. And this is confirmed here. The red line here, that's almost at 0, is the transmission that's coming in from the sides, from these importation layers into the general population. And the blue ones, which represent most of the transmission events, they're happening within the community. Okay, so you can see that this measure doesn't really help. Just to confirm this, this is what happens if we look at how, a slightly expanded model that I'm not going to explain at all, but here we're looking at more realistic travel. Instead of having importations that just depend on some numbers that we dream up, we think of another location that's contributing cases, and we look at a travel rate from that other location into the new location. Okay, and what you can see, this is for the left figure is for low travel rates, the right figure is for higher travel rates. The important thing here is, so you see community transmission means transmission that originates from someone who's already in the community, whereas transmission from importations is from outside. And the proportion of transmissions that's coming from importation, well, it's relatively high. The scale is on the right for the black curve. It's relatively high at the very beginning, but then it drops to 0 very quickly. And if the travel rate is higher, then the duration for which the transmission comes from importations is shorter. It's more intense, but it's also shorter. And once again, see all of this is happening essentially before 20 days, which is when you're not really aware that there is anything happening at that point. So to conclude, case importations, typically you can assume they will occur whatever happens. And the success of an importation from the perspective of a pathogen depends really on the transmissibility of whatever novel variant you're putting in compared to the resident variant that's already there. Quarantine looks like a relatively efficacious tool to control case importation. It doesn't spread, it doesn't stop the spread, but it definitely does slow it down. And also it's more generic. It's less stigmatizing than travel interruptions. Travel interruptions is like, yes, I'm cutting travel from India, whereas you know that there is plasticity in the transport network in such a way that people will take other routes to come. So you're essentially doing something just for show when you're doing travel interruption. Not, I mean, if you do it early enough, then you have an effect, but later on, it's essentially for show. And one of the main problems is that one other thing that we see is that the problem switches very quickly from input control, where I'm looking at trying to contain what's happening from elsewhere. And because it's clear that importations come from elsewhere, and so the novel variant, for example, if you have a novel variant that's going to arrive and you don't have it yet, it hasn't emerged within your jurisdiction, then it's coming from elsewhere. But the moment, the duration in time during which you're having an impact in terms of that control, that input control is very narrow. And very quickly, it becomes how good you are doing at controlling the variant in your jurisdiction. So of course, it's always more tempting to say, let's interrupt travel from there, whereas you should be focusing on what's happening within the borders, well, borders of whatever jurisdiction you're considering. And I said I'd come back to Thucydides. Additionally to showing that transport has been happening, of diseases has been happening for some time, I'll point out that he's also good at showing things that are constant through time. And that little sentence that I had taken out because it's not relative to movement is interesting because, well, it documents finger pointing at the Peloponnesian being the Spartans against which the Athenians were fighting. And so if you don't understand, blame the others. And that seems to be happening for quite some time. And I just advertise that 2CD is, if you haven't read that thing, it's quite interesting, even in terms of disease propagation. There's some very modern things in there. And that's it. Thank you.
Thank you very much, Dr. Arino. That was a very
Laurie, you're breaking up a bit.
presentation you gave, because it's made me from the audience, my dog right now then. So thank you very much, Dr. Arino, for your stimulating conversation. If you have questions, and I already see questions coming up from the audience, please use the question and answer function on the bottom center part of your screen, and we'll try to get to you if we possibly can. So we have a question here from Terhas, who asks, while you demonstrate that travel interruptions are not very effective for known new variants, unless it happens within 10 days within the start of a variant, travel interruptions still prevent the spread of unknown new variants, or does this model still apply in that case too?
Good question. So typically, we don't really know what a variant is before it emerges and before it's sequenced somewhere. So essentially, this applies to any variant, known or not. The important thing here being that the type of characteristics that you're seeing in terms of importation is assuming that the variant is more transmissible, but you'd get the same thing. The only thing is that with a variant that's less transmissible, then it has chances of not establishing itself. So in a way, maybe travel interruptions would be useful in that case, because the variant has less chances of making it. But you essentially, because you don't know that the variant has emerged, you'd have to essentially interrupt all travel over time, which is difficult.
Thank you. The next question is from Karenina, who says, what are his recommendations on how to stop or slow down the spread of the new variants?
So that's a complicated one. So I think there's a role. Typically, I favor quarantine more than travel interruptions, because quarantine is, as I was saying, it's in place. You can leave it in place for long durations of time. And if it's followed by everybody or by most people, this was prior to vaccination. I think vaccination changes a lot of things, I should add. But if you have quarantine that's in place, then perhaps if you're adding travel interruptions, you might have a little role. You might have an effect. Typically, I would recommend quarantine, but I mean, it's mixed. As travel interruptions can play a role, but as I was saying, they have to come in really at the very beginning. Typically, by the time you're detecting variants in your country or your jurisdiction, I think it's already essentially too late. If you start to if you detect just one and it remains one, then that's good. But if you start to detect a few, typically you can assume that there is already transmission happening. And if it's more transmissible, then that's a problem. But it's difficult to make a recommendation in general.
Yeah, it's a very tough question. You know, given the work that many of us do, we're on the line right now. I think the big question to us is like, how would, under these conditions, how would you advise immigration departments in all three countries or border control in terms of, because there's a backlog of people who are wanting to migrate. And a lot of people want to visit their relatives. So moving forward, like, what would you advise under these conditions?
In my view, as I was saying, quarantine is a good measure, because I think it can be applied even in the current, I mean, in the current situation. It's like if you show, for example, people that are vaccinated, for instance, first of all, they're less at risk. So maybe you test them before entry. And, well, I mean, not maybe, they're already tested before entry, and they're tested just after entry. So if you have a fully vaccinated individual, first of all, it's easier. But let's take non-fully vaccinated individuals. Well, we see that quarantine is a good way to ensure that people don't sort of enter the population representing a lot of risk. And I don't see why it cannot happen in terms of immigration, for example. If you're telling it's going to be an additional cost, it's going to be, okay, annoying and etc., but it's better than being denied entry altogether. So in my view, a sort of well-applied quarantine, not necessarily 14 days, because one of the things we see is that 7 is already quite efficacious, would be a good way to alleviate some of the risks. And the other thing being also that, as I mean, I didn't have time to really get into that, but one thing we remark is that there is very little contribution from those importation layers. So that would be someone who's immigrating, for instance, coming from another country into your country. The contributions of these people to the general dynamics of the disease, if there are, or if the disease is propagating. I mean, the important thing is, if you have no cases at all, then of course the contribution of importations is something you see. But if you have, like in Manitoba right now, about 100 cases a day, the contribution of importations will be probably minimal compared to that, especially if it's combined with quarantine.
Well, I'm sorry that our time is nearly up, because this is a fascinating topic, and I certainly have learned a lot from listening to you, Dr. Arino. So I'm sure that the audience will join me in thanking you for spending some time with us to explain some of the epidemiology and mathematics around disease spread, quarantining versus travel restrictions, because this is a part of the, it's an interesting way of looking at it mathematically, that some of us might not have considered. So thank you very much, Dr. Arino. For the rest of the conference attendees, I warmly welcome you to join us in the next panel, where we're launching the new social network on variants. So we've heard a lot from the science side of things about the science behind these new variants. And we have recently received funding from CIHR to continue our work, but on the social and economic and mental health aspects of the variants and how they are probably going to influence our daily lives as we move through 2021, I suspect 2022. So that's the next panel. Some of you have also asked about the presentation, if you could get a copy of it. We are recording it, so you can rewatch the presentation, and you can contact us. I actually had not asked Dr. Arino if we could share his slides, but we'll find that out for you. And thank you very much for everything, Julian. It was great. And thank you to the audience for joining us today.
Yeah, thanks for having me, and have a good rest of conference. Thank you.
And you have a good evening, Dr. Arino.